Okay, so the final portion of the airway, respiration, and ventilation is capnography and ABGs. Some terminology that is important for you guys to understand and remember as you approach the National Registry test are ventilation, as we've talked about earlier today. That is the mechanical process of moving the chest. So anytime that you're putting a bag valve device on somebody, squeezing the bag, and you're getting a movement of that chest, we are ventilating the patient. Tidal volume is the total volume of gas that is entering the lungs per breath, and that normally breaks down to about 5 to 7 cc's or milliliters per kilo of body weight. So if we figure a 100-kilo patient, then that patient should have a tidal volume of somewhere around 500 to 700. And this would come in to be important if you're in a situation where you're using a ventilator and you have to set the tidal volume for your patient. You would obviously need to know their weight and then multiply their weight by the 5 to 7 cc's per kilo so that you can get good tidal volume, meaning that you're going to end up ultimately getting good ventilation and movement of the chest. Minute ventilation. And one thing that I do want to point out as we go through some of the terminology, not only here, but when we get into endocrinology, that will be important for you guys to understand and recognize is that if you just simply take the time to read the word, it'll probably give you a lot of information about what they're actually talking about. So if we know what ventilation is, then if we add minute to that, we should be able to figure out what minute ventilation is. So the definition of minute ventilation is the total volume of gas entering the lungs per minute. And the way that they figure that out is they basically take what the tidal volume is for that patient and they multiply it by the respiratory rate. So you can see a normal tidal volume, if we're figuring a 100-kilo patient, is 500 mLs. Their respiratory rate is 12. If we take 500 times 12, we end up getting a minute ventilation of 6,000 milliliters. Alveolar volume, similarly, is the amount or the volume of gas that reaches the alveoli. Alveolar minute volume is the total volume of gas entering the alveoli in 1 minute. And then dead space, we've talked about that a couple of times already as well. We have anatomic dead space, and that is the volume of gas that does not reach the respiratory portions to have gas exchange. So if you consider 500 cc's of tidal volume, and we have 150 cc's of volume that is not getting down into the alveoli for the gas exchange to actually take place, then we end up having about 150 milliliters of dead space. Where is that dead space housed? It's housed in your mouth, it's housed in your trachea, all of the conduit or the piping that is non-functional. So the area where gas exchange actually takes place down into the alveoli, that equates for about another 350 milliliters. All right, so energy. When we talk about energy, we need to understand a couple of things. First and foremost, that metabolism requires both oxygen and glucose. If we do not have oxygen and glucose, then we're not going to have the byproducts that we're looking for, which is CO2 and energy. And energy is where we end up getting the CO2 production from. So anytime we are talking about end-tidal CO2 or capnography, we have to understand that that is a byproduct of metabolism. We have metabolism, we have all of the breakdown parts from the metabolism taking place, and now we have what those byproducts are, one of which, and the important thing to us, is end-tidal CO2. So when we look at energy, we have aerobic and anaerobic metabolism. So I'll start with aerobic first. Aerobic metabolism is oxygen and glucose coming together, and this ends up yielding a water vapor and CO2. When that happens, we end up getting the formation of adenosine triphosphate, or ATP, that you probably learned about in your initial education. And this is how we end up getting about 95% of our energy. In the event that we do not have oxygen, then we end up switching over into an anaerobic or without oxygen state. And that process is called glycolysis. So what glycolysis is, if you look at the root words again, just as I was explaining, and try to break those down, glyco obviously means sugar, and lyse means break down. So we are breaking down sugar, and that is exactly what happens in an anaerobic state. This ends up yielding alcohol, CO2, and water vapor, and accounts for about 5% of the energy. So why is all of this important? Well, because if we have metabolism, we have to understand how it works so that we know what the byproducts of the metabolism are, so that when we go to measure it and look at end-tidal CO2 readings, we understand what those readings are telling us. So if we just simply start at the beginning here with oxygen, oxygen obviously is going to go into the body, down into the lungs, all the way down into the alveoli where it crosses the pulmonary capillary membrane. And we know we have oxygenated blood, and that oxygenated blood hopefully gets all the way down to the muscles and the organs, and then eventually all the way down into the cells. If we have oxygen and glucose that are getting all the way down into the cells, we are going to end up getting energy that is yielded from that. Once we have energy, we know that there are going to be breakdown parts from that energy happening. One of the biggest ones is going to be carbon dioxide. So we now have CO2. The CO2 ends up getting into the blood, and then ultimately ends up coming back up into the lungs, and we breathe that out. So that is the respiratory cycle. And what I think is important on this particular slide is we understand that oxygen is going to go from an area of higher concentration to lower concentration through diffusion. That is oxygen going from atmospheric pressure into the intrathoracic cavity. The CO2 is higher on the inside because we have utilized the oxygen, and now we have a byproduct. So the CO2 is at a higher concentration on the inside than it is the outside. The CO2 is going to end up diffusing back out, and that is in fact what we are measuring when we look at end-tidal CO2. Normal values. Normal end-tidal CO2 is going to be a range of 35 to 45, and this is across the lifespan. It does not change from the day you were born until people are very elderly or the day they die. The normal range is 35 to 45. Physiology here. So there is an inverse relationship that exists between respiratory rate and CO2. It is always going to be inverse or opposite of one another. So the easiest way to understand or explain this is if I have a patient that is hyperventilating, we are obviously increasing our respiratory rate. Our oxygen level is going to be up. If our oxygen and our respiratory rate are up, our CO2 is going to be down. Converse is true. If we have a patient that is hypoventilating, so an example here may be an opioid or a narcotic overdose, you have someone that is not breathing adequately, their respiratory rate and their oxygen status is low, we know that their CO2 is going to be high. So what patients may benefit from having end-tidal CO2 placed on them? Well, non-intubated patients may be somebody that you could think about doing that for, and those classifications or groupings may be those with bronchospasm, asthma patients, COPD patients, so emphysema or chronic bronchitis that we've already talked about, and then our anaphylactic patients or allergic reaction patients. We can certainly think about using end-tidal CO2 in those situations. On the other side is the intubated patient, and this is very important, and it becomes a medical legal thing. So if your agency has the ability to do surveillance of your endotracheal tube after you have placed it, I would highly recommend that you do that. So in your intubated patient group, verification of endotracheal tube placement, you can do surveillance during transport to make sure that you did not have a tube that had inadvertently been removed. Control ventilations during ICP. So if you have a patient that is suffering a head injury and we're worried about increased intracranial pressure, then we can certainly use end-tidal capnography to help guide their ventilation. And we want those numbers to be on the low end of normal. So if you have a patient with a head injury and you're using end-tidal to guide those ventilations, we're looking for an end-tidal reading of around 35. Probably no higher than that, maybe 30 to 35, somewhere in that vicinity would be the number that we are looking for, because if their end-tidal CO2 gets higher in a head injury patient, it can have some untoward effects. We'll talk about that more in neuro. With CPR, it can tell us about compression efficacy. Are we being effective? The return of spontaneous circulation, as we'll see here in just a moment, and then survival predictability. Is the patient going to maybe have a favorable outcome from the information that we're seeing in our end-tidal CO2? So the phases of the capnogram, it's broken into 4 different phases. Phase 1 is the respiratory baseline. The easiest way to understand or explain this is when the patient is breathing in. So if the patient is breathing in, we should not be measuring any CO2. At that point, we would in fact be measuring oxygen. When we're looking at capnography, we are not measuring oxygen. We're measuring end-tidal CO2 or carbon dioxide. So inhalation is phase 1, and that's called the respiratory baseline. And if we kind of draw a parallel between this and an EKG, you would think of this as being the isoelectric line on an EKG. So inhalation is that baseline at the bottom. It is flat when there is no CO2 present and corresponds to late inspiration or early expiration. And that makes sense as the patient finishes expiring or exhaling and gets ready to take that inhalation breath. Those numbers are obviously going to drop back down to 0 because now we are bringing in oxygen and not CO2. Phase 2 is known as the respiratory upstroke. The respiratory upstroke is where the baseline starts to initially get a tracing and give a quantitative number that is associated with that. So we know that our range is 35 to 45. Well, if we're starting at that phase 1 inhalation or the respiratory baseline of 0, we obviously have to grow to get up to that 35 or 45 number. That is where phase 2 comes in. So phase 2 represents exhalation of a mixture of that dead space, that 150 cc's of dead space, and gases, the other 350 from the alveoli, with the shortest transport time. So if you guys can think about this from just a common sense perspective for a moment, is you finish inhalation, so you've taken a breath in and now you're getting ready to exhale. As you initially start to exhale, that gas is coming from your mouth. The gas behind that is coming from your throat, from your trachea, so on and so forth. That gas has not had an opportunity to mix and become useful as far as gas exchange is concerned. So when we start to measure that, because that was a dead space gas that is mixed with some things from the alveoli, our numbers are not going to be that 35 to 45. They're going to be much lower than that. So that respiratory upstroke is now measuring that 5, 10, 15, 20 as that person is exhaling. Once the patient has basically gotten rid of all of that dead space gas, and we are now into the true 350 that was used for gas exchange in the alveoli, we move into phase 3. That is a respiratory plateau. The respiratory plateau, or that alveolar plateau, this area here, that represents the gas that has been exchanged at the alveoli. And it is very uniform because the alveoli are going to exchange gas all the same way. So that is why we end up getting that resultant plateauing effect. Then this number here, or the very far right side of the screen where I'm kind of circling with the mouse or the cursor, that area there is where you're going to end up getting that digital readout of your number 35 to 45 or whatever that number may be. That is the most concentrated area of the alveoli and the exhaled CO2. And that is why we get that number there. And you can see that it shows EtCO2 because that is in fact where that number comes from. So respiratory plateau, it reflects the airflow through those uniformly ventilated alveoli that have a nearly constant CO2 level. And then after you are finished exhaling, we're going to take a breath in, and that is where the inspiratory phase comes. This is the sudden downstroke and ultimately returns to the baseline during inspiration. This is phase 4. Remember, because we are not measuring oxygen, it's going to end up giving us a reading of 0 if we were to measure that. And that is what is happening here in phase 4, that inspiratory phase that is trying to get us back down to that baseline, or the isoelectric line if you're likening it to an EKG. That is what is happening here. It's a sudden downstroke and ultimately returns to the baseline during inspiration. The respiratory pause starts the cycle again. So that respiratory baseline will then become the phase 2. Phase 2 will turn into phase 3, or the alveolar plateau, and then phase 3 will again turn into phase 4, which is the inspiratory phase, and that is just a continuous thing on and on. So if we put all that information together, we need to know what the waveforms actually look like, and here's what we're actually looking for. So we're looking for a normal waveform, and it should be a square box waveform. So anytime that you're looking at your waveform, what you should end up seeing is some variation of a square. And I know, by definition, that's probably more of like a rectangle, but if we can just all agree that we're going to call it a square, any variation of a square tells me that the tube is through the glottic opening if the patient is intubated. If they're not intubated, then it doesn't tell us anything as far as where our ET tube is at, but it does tell us if the patient is breathing, if they have an obstructive pattern, so on and so forth, and we'll look at all of this. So if we can agree it's a square box waveform and we're looking for a range of somewhere between 35 and 45, and in this situation, what we would do is just simply monitor the patient. There's really nothing to do other than to take a look at our patient and make sure that we're continuing to monitor them throughout transport. Remember, this is our baseline. This is our respiratory upstroke. This is our alveolar plateau. This far right side, before we have the drop back down, that is where we would get our digital readout for our end-tidal CO2 reading. So if we drew a straight line over to the numbers here, it would probably be something like a 41 or a 42 would be the readout for this particular patient. And then phase 4 is that inspiratory phase, getting us back down to the respiratory baseline. So if we have a square and then all of a sudden we lose that square, that would be concerning to us. And what that is telling you is that you've had a dislodged endotracheal tube. If you have a square and then you lose your waveform, you need to be troubleshooting. What probably has happened here is one of two things. Either the patient was intubated and the tube has been dislodged, or if the patient is intubated and is being bag valve assisted, whoever is supposed to be bagging the patient is not doing their job. So at any rate, we need to make sure that we kind of do a timeout. We look and troubleshoot as to what is going on with our patient. But anytime that you see this flat respiratory baseline, that is not a good thing with regards to capnography. What would we do for this? We would remove the tube if they're intubated, or we would bag valve assist the patient if it is just a matter of somebody not squeezing the bag when they should be squeezing the bag. But ultimately, if you're not 100% sure where your endotracheal tube is at and you're not getting good waveform on capnography, then certainly remove the tube and then go back to your basic mechanisms at a minimum. Esophageal intubation. So this is a little bit different, but the same as well. So before, we were looking at a tube that was in, and then we had a loss of tube. In this situation here with the esophageal intubation, we don't even have a waveform. So the tube, if there was a tube that had been placed, was never placed through the glottic opening. It is an absence of a waveform. There's no end-tidal CO2 that is being registered on your machine. The management here is pull the tube, bag valve assist, and then re-intubate your patient. All right, CPR. So CPR, you can see you have a square waveform. So if this person is intubated and CPR is underway, then everything seems to be good. We know that our endotracheal tube is at least through the glottic opening because we have a square. The number, however, if you can draw a line across and figure it out, it's probably around 15, something like that. And that is a normal finding for a patient that is in cardiac arrest, because remember, people that are not perfusing, i.e. a cardiac arrest patient, they're not going to have metabolism. And if they don't have metabolism, we're not going to have that byproduct of metabolism called carbon dioxide or end-tidal CO2. So what we do is through external compressions, us doing CPR, we are basically creating their metabolism for them. You can appreciate, hopefully, that us doing external compressions is not going to be as effective as them having an internal heartbeat. Therefore, our end-tidal CO2 readings are not going to be as high because we're just not as effective. If you have an end-tidal CO2 of 10 to 15 on initial resuscitative efforts after you put your endotracheal tube in, you need to make sure that those numbers don't drop below 10. If the end-tidal CO2 starts to drop less than 10, we really need to change out who is doing the external compressions because we know that they are getting tired. To take that one step further, if you guys are using any type of mechanical device to do the CPR for you, whether it be a Zoll Autopulse or a Lucas device through Physio Control, we're not recommending or promoting any of those devices, but if you have access to those and you're using them, what I am telling you is that 10 to 15 number will probably be a little bit higher. So you may see end-tidal CO2s of somewhere in the 20s or something like that, and that would not be an uncommon finding if it is using a mechanical device to do that CPR, because the device isn't going to get tired. They're going to do great compressions each and every time it does a compression, unlike the human factor. So if you have CPR underway and your end-tidal drops less than 10, you need to change out who is doing your CPR for you. All right, when we look at airway obstruction, if you all can appreciate that looking from left to right on your waveform, it is an equivalent to time, the same as it is on an EKG. So as you look from left to right, if it takes longer for the exhalation to occur, it is obviously going to change the way that that waveform looks. And that is why we end up getting this obstructive airway pattern. So most people will call that a shark fin waveform, and you can appreciate that it maybe looks like a shark fin. And that is because it is taking longer for that phase 2 or that exhalation to take place, phase 2 and phase 3 really, to take place. And then ultimately, after the patient is finished exhaling, they quickly inhale and we get back to the respiratory baseline. Kind of interesting here, this can actually be seen before an actual attack takes place. So if you put the patient on capnography and see this obstructive pattern, don't be surprised if your patient doesn't tell you a few minutes later that they feel like they're having some difficulty breathing. The machine will actually tell you oftentimes quicker than what the patient can feel it themselves. So when would we see this? Well, maybe bronchospasm, and in the classifications there, asthma, your COPD, emphysema, or chronic bronchitis, and then allergic reaction or anaphylaxis would fall into that as well. The management is bronchodilators. We got to open up that bronchus so that the patient can have better gas exchange. And if that fails to work or in a severe situation, we may end up giving them epinephrine. Remember, epinephrine has both alpha and beta effects. The beta effects that we're going to get from epinephrine, beta 2 primarily, is going to end up giving us that bronchodilation that we're actually looking for. So keep in mind, any of these obstructive airway patterns, it is a problem getting air out, not getting air in. And that is why, as we look at the exhalation waveform, it's tilted backwards, giving a shark fin appearance because it's just taking longer for them to exhale. Once they have finished exhalation, you can see very quickly that inhalation drops off and is basically a straight line back down to that respiratory baseline. All right, so what about a return of spontaneous circulation? So if you look at the first two waveforms here, are end-tidal somewhere around 15, something in that area. And then all of a sudden you notice that the third and fourth waveform drop or jump all the way up to about 30. I always kind of say this and people laugh, your CPR did not just get better. So if you had an end-tidal of around 10 or 15, and then suddenly it goes to 30, you need to look at your patient and figure out what is going on. And the guess is probably that they got ROSC. So when does this happen? Well, during CPR, you have that sudden increase. What you need to do at this point is check for a pulse. And if they have a pulse, the very next thing that you should be asking is whether or not your patient has a blood pressure, and then you should be managing it based on the findings that you get. What about a rising baseline? So a rising baseline, if you notice that the top number is not really changing, it's the bottom. Okay, the bottom is starting to rise up above that respiratory baseline. And what that tells you is that your patient is rebreathing their own CO2. And there would be a couple different reasons that this could happen. So the management here is really first and foremost, check your oxygen cylinder and make sure that you're not out of oxygen. That makes sense. If the patient was out of oxygen, then when they take in another breath, they're not taking in oxygen, they're taking in carbon dioxide. That would cause a rising baseline. If it is not an oxygen situation, your oxygen cylinder is full and it's flowing correctly, then basically what you need to do is allow your patient more time to exhale. So they are breath stacking. Basically, you're not allowing the patient to exhale fully before getting the next breath. And that will give you this rising baseline appearance. All right, so what about hypoventilation? If you remember back to the very beginning, we talked about that inverse relationship between respiratory rate and CO2. Here it is. If you can think about this hypoventilation, so a narcotic or an opioid overdose, and your patient is only breathing 2 or 3 times a minute, their respiratory rate is low, their oxygen level is low, their CO2 is going to be high. And you can see here their end-tidal CO2 is going to be greater than 45, and that is a common finding in a patient that is hypoventilating. What would we do to fix it? You have to assist their ventilations or intubate them if needed. So we basically have to fix the ventilatory effort that the patient has or does not have to try to get those ventilations up and hopefully drop that end-tidal CO2 to where it is more in a normal range of 35 to 45. Well, what about if they're hyperventilating? So hyperventilation is going to be just the opposite. So the patient has got an increased respiratory rate. In theory, they're taking in more oxygen. So those are high. Our CO2 is going to be low. And as you look here, the end-tidal CO2 in this situation is less than 35. And again, that is consistent with what we find in a patient that is hyperventilating. So what do we do in this situation? And this is a little counterintuitive. We need to slow their ventilations down. And I cannot stress this enough. If you have a patient, especially a trauma patient that has a suspected head injury, we really need to make sure that we are ventilating them to an appropriate rate of end-tidal CO2, and that should be the low end of normal. Around 35 would be kind of what I would guide for. From a national registry perspective, you definitely don't want that CO2 up into the 45, 50 area. That is not going to be good for your patient. So if you can slow their ventilations down, if they are hyperventilating or you're hyperventilating them, make sure that you slow that down until you get that range between that 35 and 45. All right, so this waveform looks a little bit different. So if we look at the waveform, our respiratory baseline is okay. And then as we look at the inspiratory or phase 2, that looks pretty normal. Phase 3 or the alveolar plateau, that looks pretty normal. We would get our end-tidal CO2 reading from right here, and we'll call it around a 40. And then all of a sudden on inhalation, we notice that we have a change in the way that that waveform has looked from the previous slides that you've looked at. Well, if you remember that from left to right, we're talking about time. So if it takes more time for them to inhale, it is going to change the slope of that waveform. And that is what is going on here. So this is an inhalation problem because it's on phase 4. So we know it's an inhalation thing. What would cause inhalation to take too long? Well, a couple things. Maybe they are intubated and you've had a cuff rupture. So now that entire ventilation that you're squeezing from your bag is not going down the trachea. It's kind of leaking around because there's no cuff there to keep it where it's supposed to be. Or maybe you're using an endotracheal tube that is too small. So for example, If you're an individual that would normally need to be intubated with a 7.0 ET tube, and I decided that I was going to intubate you with a 5.0, you could appreciate it would take longer for me to get rise and fall of your chest through a bag valve tube device. So when it takes longer for that to happen, it changes the waveform on the inhalation side, and this is what it would look like. So what would we do? Check your cuff and your tube size and make sure that that is first and foremost appropriate. And then if it's a situation where you feel like it's inappropriate, then you would pull your ET tube, bag valve assist your patient, and then possibly re-intubate them. All right, the final thing here as far as your end-tidal CO2 or capnography is something called a curare cleft. We felt that it was important to leave this information in, although some of you probably will not carry neuromuscular blockade agents like succinylcholine or vecuronium, rocuronium. There's a bunch of them out there. Some are short-acting, some are long-acting. But basically what happens is if you have given a medication, a neuromuscular blockade, to paralyze your patient so that you could facilitate intubation and or transport, if that medication starts to wear off, you will end up getting a curare cleft, or the patient may show signs of a curare cleft, and it's basically them kind of waking up from that paralytic. And what the management would be is just to consider re-administering the neuromuscular blocking agent that you had already given, or move to a longer acting if your protocol allows and dictates for you to do that. So that is what that curare cleft is and why they would have one of those develop. All right, as we look at ABGs, arterial blood gases, I know that this gets a little overwhelming for people sometimes. All I can tell you is that we're going to try to make this as easy as we possibly can. And we're only going to look at 5 different ABG types. There are a lot more ABGs out there. There are a lot of other factors that go into arterial blood gas interpretation. But from an entry-level paramedic perspective, if you guys know normal, your respiratory acidosis and alkalosis, and then your metabolic acidosis and alkalosis, then you have covered all 5 of them that are going to end up being tested potentially on the national registry, and you should be able to be successful on those test questions. So when we look at pH, your pH, a normal pH is 7.35 to 7.45. And I want to look in the column right next to it. Our end-tidal CO2, or our PaCO2 in this situation, is 35 to 45. So let me explain what PaCO2 is real quick. PaCO2 is a partial pressure of arterial CO2. So it's just collected in a different way. If you all just kind of remember that CO2 is CO2 is CO2, 35 to 45 is the area or the range that you need to be in, that'll be the easiest way for you to remember that. I always kind of kept it in the back of my mind that pH and CO2, they both have 35 and 45 in it. So the pH is 735 to 745 and the CO2 is 35 to 45. So hopefully it'll help you to remember what those numbers are. The other number here that is important is the HCO3, and that is the bicarb. And your normal bicarb is anywhere from about 22 to 26, and these are standard ranges across the board. So from a national testing perspective, I think that these are the numbers that you really need to kind of commit to memory. And these are the numbers that they're going to use when giving you your arterial blood gas for interpretation. So I'm going to jump ahead just for a second and explain to you a mnemonic that we will be using called ROAM. And what ROAM is, or what ROAM means, is respiratory opposite, metabolic equal, or even. And I'm going to explain what I mean by this in using this chart. So the first thing that we're going to do when we're looking at ABG interpretation, we always say that there are 3 names to a person or to a baby, right? So we have the first name, the middle name, and the last name. The first name is going to be whether it is compensated or uncompensated. And I don't think that you guys really need to know that information for the National Registry exam. So we're really not even going to worry about the first name. What we're worried about is the middle name and the last name. The middle name is very, very, very easy to come by. If the name or if the number is less than 7.35, we are going to call that an acidosis, because if you're thinking about the pH scale, anything less than 7.35 is an acid. Anything greater than 7.45 is alkalotic or a base, and you can use alkalosis or base interchangeably. For this, we will use alkalosis. If it is within that range of 7.35 to 7.45, then we know that we have a normal pH. All right, so here's what we do from that point forward. If I find that my pH is less than 7.35, then I know that I have an acidosis. I then look at my CO2, that PaCO2. And what I am looking for with that PaCO2 is my respiratory component. I want to know if my respiratory system is what is causing my problem. And the way that we know that is we look at our PaCO2. So if you look at the pH for respiratory acidosis, we know that my pH is going to be lower than 7.35, okay? And that is what is making it the acidosis. And I know that it is a respiratory concern because my PaCO2 is going the opposite direction. So just simply look at your arrows on this particular slide. In a respiratory acidosis, my pH is going down, my CO2 is going up. That is what we mean by respiratory opposite. Let's look at your respiratory alkalosis. So when I look at my pH for a respiratory alkalosis, I know it is going to be higher than 7.45, and I know that my respiratory component is going to be opposite. So if I have a high pH, then I know that I'm going to have a low CO2. So respiratory is opposite of your pH. As far as continuing on with the Rome mnemonic, then we look at metabolic equal. Well, we know that pH is pH, and that's where we're getting acidosis and alkalosis. We know that the PaCO2 is looking at the respiratory component. Now what we need to do is look at the HCO3 negative, which is telling us our metabolic component, and that is how we know if it is a metabolic issue and not a respiratory issue. So when we say respiratory opposite and metabolic even, what we are talking about is when you look at the metabolic acidosis, look how your pH is going down and your bicarb is also going down. Metabolic, equal, even, however you want to say that, they're both going in the same direction. A metabolic alkalosis, your pH is going up. My bicarb is also going to be going up in a metabolic alkalosis. Hopefully that Rome mnemonic helps you and you understand. We're going to come back to it here in just another minute. If we look at our ABG interpretation, it really truly should be as simple as this. We look at our pH and we say it's 7.37, that is normal. Then we look at our CO2, 44 is normal. And we look at HCO3, 25, we know that that is normal. So this is a normal ABG. There is not a problem here. What the rest of the explanation here is looking at the first, last, and middle name. I told you we're not really going to pay attention to the first name. That's just determining whether or not it's compensated or uncompensated. And I really don't think that you're going to have to know that information. What I think is more important for you all is to be able to figure out if it's a respiratory acidosis or alkalosis, or if it is a metabolic acidosis or alkalosis. The way that we do that, as I said before, look at your last name and determine if that is a acidosis or an alkalosis, and we're doing that simply by the pH. And then we figure out the middle name and we determine that by respiratory or metabolic. Remember, respiratory is through your CO2 and your metabolic is through your bicarb or your HCO3. There are only 5 to know. We know normal, okay? Normal is going to be between 735 and 745. You're going to have a CO2 of between 35 and 45, and you're going to have a bicarb of between 22 and 26. So normal is pretty much taken care of and should be easy enough to understand. The other four are the ones that might trick you up a little bit. So we're going to take a look at all 5 of these here in just a minute. All right, so we're going to start with the pH and determine if it is less than or greater than 7.35 or 7.45. And remember that your range is that 735 to 745. Then we're going to evaluate the CO2. And what we are looking for at the CO2 is whether or not this is a respiratory issue, okay? We know that it is a respiratory acidosis if our pH is low and our CO2 is high, greater than 45. We know that it is a respiratory alkalosis if our pH is high and our CO2 is low, because remember, respiratory is always going to be opposite of whatever your pH is. And remember that your CO2 should be between 35 and 45. Then we evaluate the bicarb, or the HCO3, and that is looking only at the metabolic component. If it is an acid, it is going to be less than 22. That's giving you a metabolic acidosis. And if it is a base or greater than 26, we know that we have a metabolic alkalosis. And remember, metabolic equal is telling you that both your pH and the bicarb are both going in the same direction. Remember that your normal here is between 22 and 26. All right, so the ABG Pearl, remember your Rome mnemonic: respiratory opposite, metabolic equal, meaning in the same direction or the opposite direction of the pH, depending on which portion you're looking for. So a couple practice ABGs here. So my pH is 7.31. Hopefully right away you all are kind of thinking internally and saying, okay, it's an acidosis, and it is. And then we're going to look at our CO2, and our CO2 should be between 35 and 45, but we see that this is 50. So we know right away our pH is low, our respiratory component, the CO2, is high. Those are opposite. This is a respiratory acidosis. As we look at our bicarb is going to be within a normal range here. It has nothing to do with the metabolic system. As we look at this pH, it's 7.48. We know that that is high. So then we look at our CO2, and our CO2 is 40, which is a normal range for your CO2. So we don't think that it has anything to do with the respiratory system. So now we need to look at our bicarb. When we look at our bicarb, it is 29. So my pH is going up and my bicarb is up. Those are metabolic equal, metabolic even. So we are now dealing with a metabolic alkalosis. How do we get alkalosis? The pH is high. I know that it's alkalotic, and I know it's metabolic in nature because my bicarb is also high. As we look at this, we have a pH of 7.35. That is normal. We then look at our CO2. It is 39. We know that that is a normal range. And we look at our bicarb, which is 24. That too is a normal range. All things are normal. This is a normal ABG. On this one, we look at our pH. We have a 7.33. We know that that is immediately an acidosis because it's less than 7.35. We look at our CO2. That is normal at 40. Then we look at our bicarb, and our bicarb is 21. Remember that if my pH is going down and my bicarb is going down, they are metabolic equal. This is a metabolic acidosis. And then we look at this one. We have a pH of 7.46, so that is too high. We know that that is telling me that we have an alkalotic state. We have a CO2 of 33, so that is too low. So I have a pH that is high, and my respiratory component is opposite. It is too low. We know now that this is a respiratory alkalosis. And hopefully that makes sense to you all. Please do not make your ABGs more difficult than what they need to be. Simply look at your pH and determine whether or not it is an acidosis or an alkalosis. If you just simply do that, it is going to give you a 50-50 chance of guessing the other or the answer correctly, because if you know that your pH being high is alkalosis, then you can immediately eliminate all the acidosis answers, and vice versa would be true. So first and foremost, look at your pH, determine whether it is an acid or a base or alkalosis, based on acids being lower than 7.35 and alkalosis being higher than 7.45. And then look at CO2. If your CO2 is not within a normal range, you need to look to determine if it is opposite of what your pH is doing. If your pH is going low and your CO2 is going high, we have a respiratory acidosis. If my CO2 is going low and my pH is going high, I have a respiratory alkalosis. And if it is not a respiratory issue that you're dealing with because your CO2 is within normal range, then you move to the next step of looking at your HCO3 or your bicarb. Remember, bicarb's 22 to 26. This is accounting for our metabolic issue. So if we're looking for an ABG and we think that we have either a metabolic acidosis or an alkalosis, it is going to be the HCO3 that helps point us in that direction. Remember that with Rome, metabolic is equal. So if my pH is going up and my bicarb is going up, then I know that I have a metabolic alkalosis. And if my pH is going down and my bicarb is going down, then I have a metabolic acidosis. Hopefully that makes sense to you all. I think that if you can pause, go back and watch different parts of the video here, after you get the grasp of it, you should have no issues with getting all of these answers on your examination correct. As always, if you have any questions, please make sure that you DM or email us. We'll be happy to answer those questions for you, and you can contact us through our social media platforms as well. This concludes the portion for airway, respiration, and ventilation. Thank you.